Thanks, David, for joining me today. Can you quickly, for our audience, explain who you are and what your role is?
Yeah, of course I can. I'm David. I'm a paramedic. I actually got a notification on LinkedIn the other day saying I've been working in the ambulance sector. I guess that's when I started as a trainee paramedic, kind of direct entry trainee paramedic 25 years ago on Tuesday. And today I'm Chief Clinical Information Officer at London Ambulance Service.
Nice. Congrats on 25 years. That's pretty big. Um, so you are like the head of clinical information, and a big part of London Ambulance Service's change at the moment is from the use of ambient voice technology. So can you explain how recently London Ambulance Service has adopted AI, specifically AVT, and why it was needed?
It's an interesting story, actually. Um, the last year and a half has seen an explosion in adoption of AVT, ambient voice technology, AI across all sectors. But if I rewind to, I think it was the December before last, we had some colleagues from Great Ormond Street Hospital come and see us. And they told us that they were working with a company called Tortoise as part of the then frontline digitization project. And as part of the phase 4 of their project, which was testing the use of AVT in multiple settings, including emergency departments and primary care, they wanted to test it in the ambulance service. And they said, hey, this is our plan to test it. How do you feel about it? And whilst, of course, we heard of the technology and we were watching and waiting, this was the first time that we had an opportunity to pilot and test this within our setting. So the first thing we did is, and I was fairly new to London Ambulance, not the ambulance sector, as I've already said at that point, was we thought, you know what, the best thing to do is, try it in anger, not with patients, but within the context. So we took out the founder of the organization with us on a shift, and we went out in London and saw lots of patients. We take observers all the time. Should also point out that subject to careful governance and checks and so on. Can't take anyone out, but in this case, a fellow clinician, we were able to go out and do a shift. And I suppose if I'm entirely honest, myself and my colleague, member of my team, both paramedics, we were fairly cynical about the prospect of being able to use ambient voice technology in the undifferentiated urgent emergency care environment of the ambulance service. Why? Well, so many of these products have been implemented within secondary care and and by that I mean hospital outpatient departments or within the kind of GP practice environment, uh, which is very controlled. People tend to be sat in a fairly quiet environment, not always, but often. It's a patient professional environment where the kind of discourse is fairly structured and fairly polite, for want of a better word. We were thinking, well, this can't possibly work in the ambulance environment. And what does the ambulance environment look like? Well, there's lots of different settings. We've got telephone-based clinical assessment services in our 999 emergency operations centers. We've got a clinical hub. We've got paramedics working as part of integrated urgent care and 111 services. But in the face-to-face context, there is many different types of kind of paramedic settings, and there are multiple different types of cases that you would see, and you can't tell from case to case what it's going to be like. What do I mean by that? Well, I mean, if you watch TV programs that follow ambulance services around, very often it's all terribly exciting, major trauma, and kind of exploding buildings and stuff like that. Thank goodness it's not like that for most of us most of the time. Otherwise, we'd all be on the edge of our nerves. The reality is it's much, much different to that. It's a busy nursing home waiting for 5 minutes to get someone to answer the door for a 999 call, walking through room after room and corridor after corridor, going up and finding chaos with other residents running around and trying to talk to the person who's unwell, trying to get someone to do a handover, perhaps dealing with someone who's disorientated and perhaps unable to communicate with you. try to get some kind of history from multiple different people, including to some extent the patient, often the patient, most times the patient, but sometimes they can't talk to you, members of the family. You're doing manual handling, you're doing personal care, hygiene, you're administering drugs, undertaking tests. And this is all done by the same person or persons. Whereas if you go into the hospital environment, there are discrete roles. We always used to say there are very few other professions where you go in, pump up the tires, stock the vehicle, clean out the bins, sign out the drugs, drive to the emergency, and essentially do everything until you either discharge or refer or hand over care. So no, I say it would, no two jobs are the same. It isn't quite right. Many jobs are similar, but you've got that kind of nursing home environment. You've got a busy GP practice where they've called 999 because one of their patients has got some emergency priority symptoms. You turn up to another case in a pub where everyone's shouting and swearing. There's still a fight going on. The patient's laying unconscious on the floor of the lavatory. You're dealing with unimaginable, not so much unimaginable, but just like, pretty brutal circumstances where there's lots of challenging language and challenging behaviors. And I could go on, it could be a cardiac arrest. It could be, a sudden death of someone. It could be a child abuse case. It could be a suicide case. These are not consistent type of cases. This isn't your standard kind of face-to-face clinical consultation. We're like, that can't possibly work. So anyway, we decided to try and put together a template based on the type of interaction, and rather than using a consultation kind of listening ambient, we do it as a kind of post hoc dictation using the same large language type technology to create a template, and it worked so well we were taken aback by it. So we thought, let's pilot this and see how we get on. So we set about a pilot, and in order to kind of, and this is a really important part of our journey, what we did is we wrote out to all of our clinicians working in our ambulance operations. That's the frontline traditional ambulances turning up to 999 calls, but also our clinicians working in our clinical hubs. And we said, hey, can we have some volunteers? We've got up to 10,500, 11,000 staff and volunteers in London Ambulance Service. We had about 20 people come back and volunteer. I don't know what those numbers look like. Did everyone read their emails? Were people available on the shift? All of that stuff. But I thought it was pretty good. We had around 20 people turn up into an event that we ran where we walked them through the technology. We showed them what we were trying to achieve, and we asked them to sign up as early adopters as part of a pilot. It undertook an interview, kind of pre-use. By interview, I mean a qualitative survey, so that we could understand what their baseline perspective was in terms of clinical documentation, workload, pressure, and so on. And then we undertook a post evaluation survey as well, which gave us some really interesting results. And what we did was around 7 or 8 clinicians were using it in face-to-face, and we had 10 desks within our clinical hubs, which have 40 or 50 desks at any one time and have anything up to 100 staff working over 24 hours a day. And the clinical hub is that telephone-based environment to test. And we were able to compare, certainly in the clinical hub, a significant number of cases using ambient voice technology to support the clinical documentation and notes with the rest of the people not using it. In ambulance operations, it was a much smaller sample size. There was no controls over case selection and so on. So whilst the indicative, findings were really interesting, it was the case that we couldn't say for sure this made a difference. And what we found was, and I'm going to come back to the productivity thing in a minute, but we found a 15% improvement in productivity in the clinical hub clinicians, which is massive. That could equate to 100 or 200 extra patients a day that you could be able to support with the same number of staff, depending on the calculations you did and how busy you were. But it also, and this is the most important bit, is it was overwhelmingly positive from the clinicians involved. We had people clamoring to be working on the desks that had the ambient voice on it. And we had no obstacles to adoption. I wouldn't say everyone wanted to do it, and there's still people that don't like to use it. They're the gifted, talented people whose amazing brains allow them to type and talk and look and engage in a meaningful way, and create great documentation. And the rest of us are slightly more human than, or and unhuman, you understand. But the rest of us are slightly more fallible, should I say, and struggle sometimes with the multitasking. And keep in mind that the control room environment is super busy, multiple screens, things flashing with loads of busyness and noise. So what we found from the survey outcomes was that, and the qualitative interviews, is it was an overwhelmingly positive picture. People felt that they had more time to properly engage with patients. They felt that they were able to look at their patients while they were talking to them, rather than leaning over the computer or the pad and having to type. And they felt that their notes were more consistent. In parallel to this, I haven't really touched on it, but there was a huge governance piece to do, both in terms of clinical safety, the DCPO 160 stuff, the checking with the MHRA regulatory requirement. Keep in mind, when we started doing this, there were no national guidelines and national registry, and it was all slightly unclear. So we had to feel our way and try and do and adopt best practice so far as we could. And yeah, I think it's fair to say that we've been really impressed by the potential, but it's not without its challenges, because of course there is no such thing as a panacea yet.
Sure. Now, about the challenges, because you've written an article for Rewired, I think, and you mentioned one specific challenge that you encountered. Can you explain what issue that was and how you addressed it?
Well, can you remind me which one it was?
That I particularly remember reading was the AVT system would log something that wasn't discussed.
Yeah. Okay, so that's really interesting. We've got this emerging term that we call impertinent negatives. And impertinent negatives are, let me explain what I mean. I mean, all the clinicians will immediately know what I mean, but whether you're using AVT or you're using templated documentation, there is a risk that when you look for stuff and you don't find it, that you can document it in a way that suggests that it was a negative finding. So for all the non-clinicians out there, and it stands to reason what I'm saying, say you've got you never think of a good example when you're on the spot, can you? I'll do my best. You've got chest pain. You measure an ECG, take an ECG, and the finding could be that the ECG was normal, or it could be that the ECG was abnormal. But if you wrote a template in such a way, whether it was a physical template, so say you pre-created a set of documentation notes that you would use in your clinical practice saying ECG normal or ECG NAD, nothing found. If you had not conducted an ECG, but you left that in your template, it would suggest that the ECG was normal rather than it being a non-finding because you hadn't actually measured an ECG. And we found the same with AVT. We were creating these really detailed and robust templates to drive our documentation. But we found if we engineered them in a way that was essentially looking for the absence of any reference to it, we could end up with, in the documentation, it written in such a way that it could be understood by another clinician to be a negative finding, i.e. a finding that wasn't there and was examined for, as opposed to one that wasn't examined for and therefore wasn't found. Does that make sense? Really hard to make it make sense, but we found exactly the same problem where clinicians have used templates, and they've written their templates, and it's like no chest pain, no breathing difficulties, no neck pain, as a prompt for them to go through and do their clinical assessment, if they don't delete the line where they haven't examined for it, it suggests that there was a negative finding. We found the same with ABT.
Interesting. Okay. How do you get around that?
So for us, it's been about working with the supplier, going through our clinical safety process, removing the parts of the template or discontinuing parts of the template where it was coming up with those type of findings, having a clear feedback process for people when they're using the interviews to be able to press a button and say, "Hey, got a problem with this one," but also taking a continual view of the quality of it. And I think a key factor is those of us and this is the role of clinicians in the digital space. We're all practicing clinicians, um, and actually all paramedics. We're seeing this being used firsthand, either doing it ourselves or sitting with our colleagues seeing it. And because we're holding that wider governance view and the oversight of it, we're able to then work in partnership with the suppliers to re-engineer both our templates, but also for the supplier to look at their core engineering about how the product works to make sure that we can do it. Now, you can imagine, if you were thinking about allergies, for example, or medication, documenting those in a way that wasn't helpful would be very, very serious, potentially indeed, as would a potentially negative finding when one wasn't found. And we found the nuances, particularly around mental capacity and things like lasting power of attorney, quite difficult to write in a way that makes sense. Keep in mind that this will probably be, within a very short amount of time. This won't be a problem because the technology will evolve at such a pace that these problems will iron themselves out, probably. And then the second bit is, if you don't mind me going on into kind of second area of consideration, and there are many actually, but a second area is, and you hear people talking about this all the time, keeping the human in the loop, keeping the clinician in the loop. That's something that people use all the time. But there is an alternative thing that you need to think about, or if you like, the opposite, which is you need to think about how you keep the human in the loop in the consultation. And I know they sound like I've said the same thing, and I have. We want in the the clinical consultation space, we want to keep clinicians there. But picture it. You've had a busy shift. You've seen X number of patients. You're 11 and a half hours in. Your newborn baby has been yelling all night and you had a rough night's sleep between your shift. Or you're on a night shift and you're naturally tired because humans are often tired on night shifts. And there you are conducting a clinical assessment and you've got the safety of the ambient voice listening to you and your mind drifts off. It's not something that people want to think about, but humans are humans, and we've all done it. In the past, you had no fallback. You'd have to say, "I'm really sorry, can you say that again?" And that's okay, right? But, talking to our clinicians who use this, say, I have to constantly remind myself that I need to stay engaged, particularly when I'm tired or feeling overwhelmed. So there's something that we have to do as a group of professionals and industry to think about this at the point of adoption. This isn't a plug and play and walk away. It's not like that at all. This requires us to work closely with our clinicians, think carefully about what education and development requirements are there. And as we move out of pilot to full adoption and implementation, it isn't just about deploying software. It's about deploying core knowledge and skills and understanding, both at an undergraduate level, but for people in practice, to be able to work with people side by side with the supplier to make sure that as we implement this technology, it is safe. Our practitioners can do their practice alongside it in a way that makes sense, and we can continue to hone and improve it.
It's interesting, isn't it? Because there is an argument that that's always going to happen because everyone has specific times at work where you feel very sluggish and it's a lot harder to pay attention. And maybe in the past, if a clinician or a paramedic was feeling very tired or feeling very overwhelmed, then they might have missed things anyway. And because they don't have the AVT to fall back on, maybe things would have gone unnoticed. I mean, it's really hard to judge. Um, there is a danger, obviously, that you could over rely on the system, but on balance, is it probably doing a better job than if you didn't have it?
The truthful answer is who knows? We'll only know in time when we're able to look at trends and incidents. And that's why having a really close working relationship with your quality safety teams and your incident teams is really important as you implement this stuff. You need to be able to keep a system-wide observation of what's going on to understand that you're quite right. People were always getting tired and drifting off a bit. And this is a grim reality. And I don't want, if there's any patients out there, members of public listening to this podcast and thinking, well, that sounds terrible. I'm not saying that people aren't listening at all, but we're all human beings. You get a jolt of pain. Perhaps you've got some bellyache. I don't know why. There's many reasons, isn't there? It may distract you for a minute, or there's a loud noise outside. And you're exactly right. These systems provide a true digital co-pilot, co-clinician to listen to it. But because in our workflow, we require our clinicians to clinically validate the outputs of the AVT. They can't just copy and paste it. They have to review it and then provide a certification statement to say that they have clinically reviewed it. It's still needed to be in the game. You still have to have your head in the game. But I can think of cases, one case involving a highly distressed person in a very challenging environment that extended over a period of 2 or 3 hours. And I had the ambient voice listening throughout. It reminded me of a lot of things that I just simply wouldn't have remembered in the clinical documentation. And would those have been huge gaps? No, because one of the skills that you have as a clinician is to hold on to the core information and be able to assimilate that into a diagnosis and a care plan and ensuring you capture relevant information. But what it did do in that case was enhance the quality of information I was able to share.
Mm, mm. That's fantastic. Yeah.
It's both sides of it. But you need to be able to have those conversations with colleagues as you implement this stuff and say, these are the things, these are the bear traps. These are how you continue to be a great practitioner with this support.
Were there any other big problems that you encountered?
I've got a fairly long list of challenges for doing this stuff. But just like most of the other successful things I've been involved with over the years, actually, the thing that's been the resounding memory of this pilot has been the keenness for adoption. And it is also true to say that very, very reasonably, my colleagues who work in the operational teams have also been cautious of implementing technology that was untested and unproven that could have a negative consequence on the way we deliver care to patients. And that's an entirely legitimate concern. So is that, an obstacle or a problem? Is that a bear trap for ABT? No, it's not. That's a crucial piece of making sure that you phase adoption and implementation in a way that allows you to bring all of your stakeholders on board with you. So one of the things I can tell you, which is a resounding, exciting success, is for our neurodiverse workforce members, on balance, they have found the adoption of ABT to be much, much more impactful in terms of helping them at work. I, like many of my colleagues who work in emergency services and the ambulance service, have ADHD. We probably didn't know what it was called 25 years ago when I started. Just knew that we were a particular type of person that loves a crisis. It also means that, things that come alongside those type of neurodiverse conditions, I'm loath to call them conditions or diagnoses. They're really just who we are, right? We're just learning what it means to be human each day by day. But they come with huge strengths, but also challenges. And some of those challenges, speaking for myself, even though I know our electronic records inside out and have been working with it for years, when I'm busy, I struggle to remember where stuff is. being able to use technology to help me navigate the record and create a record in a really supportive way is important. In the same way that if you have challenges with dyslexia, and let's face it, the Greek and Latin origin medical jargon and language isn't easy for anyone unless you were, had the good fortune, and I say that with some irony in my voice, to learn Latin and Greek at school and can't remember a word of it in your 50s. But the truth is it's flipping hard anyway. And actually being able to have something that helps you write really good quality records that you don't feel a bit foolish about. And also, let's be honest, as my fingers get fatter and I get older and more incompetent, I don't seem to be able to type on screens as well as I used to be able to in my 20s and 30s. And it helps us all with the quality of our records. So for our neurodiverse colleagues, we've seen in some cases up to a 100% increase in productivity because they've been able to improve the speed and quality of their recording, which is really impressive stuff.
Mm.
And so we made a decision early on as part of our pilot to roll it out to any neurodiverse team member, whether they have a diagnosis or it is a self-identified problem. We want to reduce barriers to doing great clinical work in LAS, and that's why we took that approach. But we needed not to roll it out en masse to everyone, because once you do that, you can't measure and contrast.
Yeah, sure. Speaking of which, where are you at with EBT at the moment? Did you say that it's left pilot stage now, but it's not widely implemented yet? Or?
Yeah, so we have it fully implemented across all of our clinical hubs. So we've got 2 main clinical hubs and a number of outpost clinical hubs across London. We have it rolled out. I think the last numbers I saw were up to about 900, possibly more, of our clinicians. And this is where now I feel under pressure. My brain's empty and I can't remember the number, but we've got thousands of clinicians in the organization. So, it's a significant rollout. And we've got varying levels of adoption by the people using it. And we also have an extension of our pilot running with colleagues in South West Ambulance Service in their Emergency Operations Centre clinicians and in South East Coast Ambulance Service. So we work as part of the Southern Ambulance Services Collaborative and are collaborating in that way. But actually, as a whole sector, we've come together, we're sharing our documentation, our clinical safety cases, our approach to governance. And that way, we're both learning from each other and supporting each other. And it's been a really exciting, piece of work to see people collaborating in the interest of both patient care, but also our clinician population.
That's fantastic. And do you think that there are any other bits of AI or just tech in general that you now think London Ambulance Service absolutely needs? So we've got ABT. Do you think there's anything next, or do you think it's all about getting this right first?
Got this. You asked the question. I've got this image of me going into the sweet shop in the late 70s and 80s and being a child with 6p and having to buy quarter-p sweets and not knowing what to do. It's kind of a bit like that in the AI tech space. But I think if you just kind of pull back a bit and go, you know what? I did the Digital Academy program a few years ago, and I remember there was a speaker from the US, and he was talking about the adoption of electronic patient records in the US. Can't remember who it was. Probably should do. Probably a very, very important person whose name I should remember forever, but I couldn't. And he was saying that, and that was what, I don't know, just before COVID. In COVID, I was doing that stuff. He was saying that there were still hospitals in the US which advertised consultant roles that they had paper systems. Such is the level of dislike of digital systems because of the way it impacts with that patient to interaction. You can't look at them like we're looking at each other because you're busy looking at the keyboard, because most people can't touch type. And even if they can, it isn't always perfect. They'll have to click and navigate around. But there's also the fact that, when years ago, an ambulance clinical record was like this size, little, A5. I always keep that to show what it looked like. By the time I had qualified as a paramedic in the mid 2000s, it was a sheet of A3. By the 10 years later, it was a sheet of A3 in multiple different self-replicating forms. And now we've moved to electronic records we've just opened the floodgates. They get bigger and bigger and bigger. And you have every specialty, every audit team, every governance team say, we need to record this, we need to record that. And we've got a, football field size record now where in truth, there's only a handful of fields that we use for almost every case. Many are used very infrequently, in the low percentages of time. And what does that mean? Well, it means that we've got, these super complex records, which are hard to navigate, can't remember where they are. They're not necessarily filled in equitably, and it drains the time of clinicians. It impacts their ability to deliver care because you're busy doing admin, right? The world has changed in the last couple of years. We now have technology that allows us, whether it's access to records, which are integrated into our electronic systems, whether it's the ability to use ABT or databases that talk to each other, which allow you to bring information together in a way that you never could before without semantically interoperable data. Suddenly, tech can improve productivity. So all of the losses that we have given to tech, which have slowed us down in the last 20 years, I believe we can now regain with better user interfaces by being able to use multiple different types of input, incorporating information from other records, listening to us, automatically bring in data from systems that we use to take blood pressures, ECGs, echocardiograms, ultrasounds, whatever it is in whatever setting. And that's the exciting bit. So tech needs to be invested in hugely because it will pay for itself. And not that any policymakers will be listening to me. And we have a difficult time, don't we? We've got an awful lot to do. We've got competing pressures at a national level. And it's absolutely right that we want to and continue to invest in our clinical workforce. But I would argue that this is the time to also invest in our clinical digital workforce so that we can release those things that allow clinicians to enjoy their job more, patients to get better, safer, higher quality care, and that in turn releases operational efficiencies and productivity gains.
Sure. Awesome. Now, lastly, you're going to be speaking at Rewired on the 26th of March. Can you tell us what you're looking forward to about that day and what you're going to be talking about?
So look, I guess I want to tell a similar story to the one that we've spoken about today, which is, the exciting opportunity of being able to use technology to really disrupt the status quo in how we do our business today. And we have to look forward to a future which allows us to create records, code records, share information, and use information in a way we've never imagined before. And that has to change soon. It has to change because we've got compelling requirements. We've got financial challenges in public services. We've got increasing needs for an aging population. We've got all sorts of other kind of competing priorities for national funding. No one wants to be talking about wars and conflicts, but this is the reality of the world we live in today. And all of us are committed to delivering, we work in healthcare because we want to deliver good care. So there's an opportunity, I genuinely believe, and I haven't just drunk the Kool-Aid, for us to be able to do better for more, make life better for our clinical colleagues, give better clinical outcomes. And to do that, we do need to embrace the technology thing. But of course, prioritizing that, being able to innovate in an agile enough way, having good governance, our systems weren't set up to fail fast, and nor can they afford to do so when you're talking about patient care. But my kind of key message is, hey, this is an example of how technology can seriously disrupt the status quo in a positive way. Therefore, we need to invest in it some more.
Excellent. Well, I very much look forward to it. Thank you for joining me, David. It's been a pleasure.
Likewise. I don't think I've sat so still for a long time.
It's the ADHD.